So I did an article called The Effect of Neoprene Thumb Abduction Splint on Upper Limb Function in Children with Cerebral Palsy. That's a mouthful. So basically, they wanted to see how to optimize engagement in occupations for children who have cerebral palsy, because typically they're in a spastic contracted position, and that really impacts hand movements and grasp and pinch. And so what they found is that obviously children with cerebral palsy have limitations in upper limb and hand function, which leads to a dysfunction in occupational performance, which you can imagine. Movements seen are typically slow, weak, and uncoordinated. And then they also found that there's an incomplete finger dissociation, there's deficits in tactile sensation. However, there is an increased deep tendon reflex and tremors. Children with cerebral palsy also display spasticity, hypertonicity, which they're contracted and their muscles are shortened so much that they're in that constant flexor position, especially in the upper limb. And then a lot of them display a thumb in palm deformity. And I tried to show a picture. I'm not sure if you can see it very well. Let's see if I can move that. So basically that's just a flexed and adducted position of the thumb, which really in turn affects pinch and grasp. So they're not able to do buttons, they're not able to even hold their pencil. So this study wanted to see how can we optimize engagement, and to do that they decided to make a splint. So they decided to make a splint made out of neoprene material because it's soft and it allows for active movement. And so here's a picture of what that actually looks like. It fits on the thumb in the web space and around the palmar and dorsal surfaces, and then it's secured on the ulnar aspect. And so it keeps the child's hand in an abducted and unopposed position, so it really opens up that web space to allow for functional activities. And so the goal of using splint in OT for a child with cerebral palsy is to stabilize their muscles, stretch and lengthen the muscles, prevent contractures, and maintain range of motion. And so OT uses functional and non-functional splints. The one that they used in this study was the neoprene, which is a functional one, and that's just to help improve function and meaningful activities. So in this study, there were 28 children between the ages of 18 months and 6 years who displayed a thumb and palm deformity. They were treated at the clinic at least once every other month, and children were excluded if they had a comorbid illness or if their hand was in a constant static contracted adducted position, and if they had a comorbid illness such as hydrocephalus, tuberculosis, meningitis, they excluded them from the study because they didn't want improvements seen to be due to the illness. And so they wanted to ensure muscle strength and tone wouldn't be compromised because of the study. So for the control group, they received home therapy, but they didn't get a prescription for a splint. And then the intervention group participated in home programs and splinting programs. So these programs consisted of stretching, active exercise, and practice with ADLs. Parents performed the stretching and they assisted with the active exercising if the child needed help. So the child would initiate the movement and then the parent would help out. So for the stretching, they did trunk rotation, rolling, and reaching, and that's just to try to get them to have mobility in the shoulder and improve their range of motion. And then children had an initial assessment and then a final assessment after 3 months. And so what they ended up having was they started with 28 people for the initial assessment and ended up with 19. So assessments used were the Gross Motor Function Classification Scale, or GMFCS, and this determines the extent to which the child can walk with or without assistive technology. Then they also use the Quality of Upper Extremity Skills Test, or the QUEST. It includes 4 aspects of hand functions, which are dissociated movements, grasp, weight bearing, and protective extension. And so a little bit more about the QUEST assessment. Dissociated movements were observed for how the child can reach for an object. It evaluates range of motion in the shoulders, elbows, forearm, and wrist. And then they also assessed their grasp. So they watched children pick up blocks and stack them. And so they noted what type of grasp the child was using, whether that was a tripod grasp, a digital pronated pincher, or radial palmar. And then they also assessed their weight-bearing position of the hand and arm. So the child was either in a prone or quadruped position without equipment, and they just noted how the hand was placed, whether it was on, like the dorsal side or the palmar side. And then they also assess their protective extension. So this is whether the child is able to prevent themselves from falling when their weight is shifted. So this was in a cross-legged position, or otherwise known as a ring-sitting position. And the elbow is either extended or flexed, and whether the hand is open or closed when they have that writing reaction. So a little bit about the QUEST assessment. It's a criterion reference assessment, which means that it's sensitive to what the child can do, not compared to like a norm for other kids their age. So the results for dissociated hand movements, it showed greater effects and movements with the splint than without. For grasp, they use more functional grasp with the splint on than without, and that just kind of makes sense because they're in a more functional position. So for weight bearing, there was improvement seen with the splint on, because that web space is open, so when they're in that position, they're able to bear their weight, and the weight is distributed just a little bit more. For protective extension, there was slight improvement, and that's due to the functional position of the splint. However, in a child with cerebral palsy, writing responses are typically more delayed as compared to a typically developing child, and that's just because they have slower reaction time as compared. And the vestibular system is activated during this time, and spasticity increases, which is why there wasn't a whole lot of improvement with this variable, but there was some with the splint. And so some takeaway points. Obviously, there were vast improvements in hand function with the splint and upper limb function with the splint also, but improvements weren't carried over when the splint was removed. And so what they suggest is that children continue to participate in activities with the splint on. And then they also noted that a combination of the home program as well as splinting is the best for lasting improvements. And that's all I have. Thank you.